Good evening, doctors. It's indeed a great pleasure for me on behalf of IPCA Laboratories to welcome you all for this session for today evening, which is on the spectrum of the clinical practices on hypertension as basically a therapeutic compass, which of course going to be an interesting topic of discussion for today. And we at IPCA are overwhelmed with all the support that you've been extending towards us when we started this focus on hypertension, and all the guidance and the support that you've been giving to us academically and also in the progress of the molecules which we have. With this, we have a lot of initiatives in the academic front which you've taken, which is more on the social media as well as more on the patient awareness through doctors, which is reaches to the society. With this, a new initiative from IPCA is one of the CPR app which we launched recently on the first time in the country, which again is for the public and one of the public initiative. With this, it's my great privilege to welcome Dr. Indranil Purohit, who again is from the Son of the Soil, who is heading our medical clinical affairs over here. Over to Dr. Indranil to take over the proceedings.
Good evening, everybody. It's a privilege for me to be over here because I'm from the city of Calcutta. I've graduated, did my medical education from Calcutta Medical College, and subsequently, after a brief stint in National Health Service in cardiology, then I joined the industry 14 years back. And it has been a nice journey being associated with all of you. Today, I would like to welcome our speaker and chairpersons of this program. First of all, I would like to welcome and introduce Dr. Venkatesh Ram. He is a Padma Shri, I would like to say, the Padma Shri Dr. Venkatesh Ram. He is a known face in the field of hypertension globally. He is a director, academic and scientific affairs, Indian Society of Hypertension, professor of clinical medicine, University of Texas, Southwestern Medical Center. He is a director, Texas Blood Pressure Unit, Dallas. He's also the Dean Maguire University, Medical School of Sydney, Australia, India campus. He's the founder member of American Society of Hypertension and the chairman board of governors. He's rated one of the topmost hypertension experts in the world and listed in Who's Who in the world. He's an author. He has authored more than 410 publications and 9 books in hypertension management. He has extensive lifelong career as a clinician, as an educator, researcher in hypertension. He's a recipient of Lifetime Achievement, an award of the Moser Award from the American Society of Hypertension, and as I've told, he received Padma Shri from the Indian government for his work in hypertension and prevention of heart disease. Welcome, Venkatesh sir. Next, I would like to welcome and introduce the chairperson and moderator for today's meeting. I think Professor Dr. Rabin Chakravarti, he needs no introduction, I think. He's a senior vice chairman and head cardiology services, as a senior consultant cardiologist and electrophysiologist in Manipal group of super specialty hospitals of India. He's associated with, as a member chair in numerous bodies. And so I would like to next introduce our chairperson, Professor Dr. Partha S. Banerjee. He's a DIP card as well as done in MD internal medicine. He's also DM in cardiology and fellow of American College of Cardiology. He's a past president of CSI. He's a chief intervention cardiologist, Manipal Hospital, Kolkata. He's a former head of Department of Cardiology, Medical College. He's a fellow of American College of Cardiology. He's represented in many national, international conferences, faculty, and he has various publications in cardiology in different national and international journals. He's an expert in coronary artery intervention, pacemaker, and ICD implantations. So I would like to welcome Professor Dr. Banerjee. Next, I would introduce our next chairperson for today's meeting, Professor Dr. Abhijit Tarafdar. He's a senior consultant nephrologist, Department of in Apollo Clinicals Hospital, Kolkata. He's an ex-professor and head, Department of Nephrology, Institute of Postgraduate Medical Education and Research Center, Kolkata. Welcome, Professor Dr. Abhijit Tarafdar, to today's program. Next, I would welcome and introduce our next chairperson for today's meeting, Dr. Sunil Leela. He is an MD in internal medicine, DM in cardiology, also a fellow of ESC, AAHA, and SCAI. He is a senior consultant intervention cardiologist at R.N. Tagore in Kolkata. He is a senior consultant cardiologist also in ILS, Salt Lake. He is the chief of cardiac services at Narayana Multispecialty Hospital, Barasat. Trained in interventional cardiology at Mount Sinai Hospital, New York, and several publications in journals and books at national as well as international level. Welcome to today's meeting, Dr. Leela. Next, I would like to welcome and introduce, is he in the meeting? He's joined? No. Dr. Arindam Pandey, he passed his MBBS with honors. He's an MD internal medicine, DM in cardiology, also fellow of ICC, ESC, CAI from USA and ACC as well from USA. And he's also the fellowship from Royal College of Physicians, Glasgow. He's the senior consultant interventional cardiologist in Medica Super Specialty Hospital, published more than 60 articles in different international and national peer-reviewed journals. He's contributed 13 chapters in different medical textbooks. He's an associate editor in upcoming textbook of chronic coronary syndrome. He's a former consultant and academic coordinator, DNB cardiology and PGDCC training department in Apollo. Is an observership in National Heart Center, Singapore. Also, I don't know whether people. He's also in the YouTube channel, and he does many programs on cardiology and health issues. So next, I would welcome Professor Dr. Ravin Chakraborty to the stage to take on the proceedings for. Thank you.
Good evening, everybody. I think without wasting much time, we'll straight away come to the program. And this evening, we are going to share our our experience, to some extent, our vision about hypertension. As we all know, that hypertension today is more of a public health challenge, a global public health challenge. I think more than 1 billion population all over the world is suffering from hypertension, and an adult subgroup of population is hypertension alone, it accounts for more than 17% of morbidity and more than 7% of mortality. So keeping that in mind, it may be quite appropriate to consider hypertension as such just a public health hazard like smoking. So we would like to share our views, and to start this discussion, none other than Professor Venkat Esram, a close friend of mine, an authority on hypertension, a global authority on hypertension, and also a leader in World Hypertension League. He's going to share his ideas, his thoughts, and with myself and our senior colleague, Professor P.S. Banerjee, Sunil, Dr. Professor Avijit Taravdar, we are going to share our thoughts. And please feel free, ask questions, have more of an interaction, and whatever stupid thought that you may carry, do share, because the moment you share, you realize that our thoughts are even worse than that. So that's how we learn, and that's how we, at the end of the day, we all cater our community, the community gets the benefit. With that, may I invite Professor Venkat Esram, Padma Shri Professor Venkat Esram, to deliver his talk. And meanwhile, can somebody remove these chairs, because we don't need. This is a non-political meeting. Take it away. So as we talk, please, if you have some question, you may write down on a piece of paper. That would be quite decent way of discussion, or also at some point you can freely ask. But let us talk. Everybody should talk, and at the end of the session there should be huge noise. So that some wedding function is going on somewhere, they should realize that wedding is less important than a medical discussion. Thank you very much.
Good evening, ladies and gentlemen. Good evening, Shubh Sandhya, in your language. I'm glad there are no politicians here because our chairperson has asked all the chairs to be removed from here. So it's a good thing that we are in a very scientific environment. I am also very privileged to be in the company of wonderful doctors in the audience. Our chairperson, panelists, all of them are known to me for a long time. And we are very good colleagues and we have camaraderie and friendship. And I am grateful for the opportunity given to me to make some remarks about hypertension with this group. And I have been somewhat of a historian along with the medical field throughout my career. And Calcutta has always been a very special place for some of us who were born near or after independence. Because in the history books in primary school, in middle school, there was mention of so many people from Bengal who have contributed to the plethora of social fabric, starting with Raja Ram Mohan Roy, and other fields in terms of science, J.C. Bose, and in terms of national honor, Subhash Chandra Bose, and in terms of economics, you have a Nobel laureate who is still alive, which is good, one of the few people. And also contribution of Bengal to cinema, both here as well as in Mumbai. And contribution to the sports, for sure, also. And when you look at the religious order, then I had a wonderful privilege to meet Mother Teresa on 2 occasions. And I still have a small letter that she has written to me with her handwriting. I'm not able to preserve it because I have so many people. It fades no matter what, the ink fades. And then of course Ramakrishna Paramahamsa and Vivekananda and started with Chaitanya Mahaprabhu. So when you weave all these things, you have a fabric of excellence, so I want to pay my tribute to all of you. My responsibility is to cover few aspects in hypertension. This is not a hypertension tutorial. This is not a huge seminar on hypertension, but I'll touch on few things that are of practical interest, As Rabin Chakrabarti has mentioned that the time is for discussion where you can ask anything, any questions you can ask. I have never fielded in my life any dumb question. I have never fielded any dumb question. I may have given dumb answers, but no question has ever been dumb in my opinion, and I say it from the heart. So that I want you to feel comfortable, not be shy, challenge, discuss, etc. Now, the reasons are completely not clear, but it is evident that because of our genetics, we are at a high risk for complications from hypertension. And you will remember when European guidelines, the 2018 were released, they have suggested that people from South Asia at the same level of blood pressure as Europeans have 40% increase in cardiovascular risk at the same level of blood pressure. Same level of blood pressure. They use the word South Asians. It is a very political word and a very, very clever word. What South India means is Indians. They don't mean Pakistan, they don't mean Bangladesh, they don't mean Sri Lanka. No. The word South Indians is actually synonymous in the Indians, and we have to accept that. Now, after that, because there is always a friendly competition or friendly fire between ESC and ACC, ACC lost the chance to make Asians a separate category, and they have appended their guidelines in 2019, and they have now put Asians at a higher risk. And World Health Organization, which did not want to be left around, International Society of Hypertension, has also put South Asians as being a high-risk category. So, ladies and gentlemen, for multiple reasons known or yet to be known, we are at a high risk as a result of blood pressure. That means we are going through the red light most of the time in our journey. Now, blood pressure 130 or 80 is the current normal blood pressure, and that is the blood pressure that you should try to achieve as much as possible. Now, somebody will say it is very difficult in clinical practice. I agree with that also. It is very difficult, but that should be the goal. That is what we should tell the patients, because if you feel that is not the goal, then the patients will not benefit. So as much as possible, try to reach the blood pressure of 130 by 80, irrespective of the age. Age is not a criterion that restricts the definition of hypertension or expands it. If the patient is able to tolerate therapy, you should be able to tolerate therapy as much as possible. Now, majority of cardiovascular complications occur in people under the blood pressure of 140 over 90. I did not say above 140 over 90. Please mark my words. Vast majority of cardiovascular complications occur in people who have a blood pressure that is less than 140 over 90. So somebody will ask, Dr. Ram, what does it mean? It means those people who have a blood pressure between 130 by 80 and 140 by 90. So ladies and gentlemen, the bulk of complications occur between 130 to 140 and 80 to 90. No doubt about it. But this is not a new finding, by the way. This is a finding that is almost 100 years old. And this is a study that was done nearly 100 years ago, let us say, it's 90 years back, where they have suggested what would be the life expectancy at the level of blood pressure. If you have a blood pressure of 120 over 80 at that time, you are expected to have a pretty decent life, longevity. But you add little bit of blood pressure, you will lose 4 years of life. If you add little bit more, you lose 8 years of life. If you add little bit more, you lose 16 years of life. So instead of having a life of 76 years, you have cut it down by 16 years when the blood pressure is 150 by 100. So when you see patients in the office, which all of you do because you are very busy in clinical practice, you should not ignore 150 or 100 because it is better than 160 by 110. You should not ignore. Because 150 by 100, if it is do anything, you have cut down the life expectancy. Ladies and gentlemen, as they say, we have come a full circle from 1935 to 2025 that the blood pressure should be as close to 130 by 80, 120 by 80. Now, let us look at the evidence. This is a very, by the way, this is the reason why the new guidelines suggest lower blood pressure. Supposing you take the blood pressure from 120 to 130. Take it from 120 to 130. Take it from 120 to 130, the cardiovascular mortality, all complications increase. Now you take it from 120 to 40, the complication rates increases, including stroke and myocardial infarction, by 100%. So between 120 to 140, there is a graded increase in complications. So the point is that so-called mild hypertension is actually malignant hypertension. So this is one term where mild becomes malignant if we don't control it and contain it. Now, these are the complications noted on a meta-analysis in people who had a blood pressure greater than 140 systolic and less than 140, usually in 130. So if your blood pressure is more than 130, there is no benefit at all. There is no benefit at all. But a significant benefit if it is lower if possible. Now, the question that comes up and which is real, what do we do with somebody who is an elderly person? And what happens when you treat hypertension in the elderly? A number of trials have shown when you treat hypertension in the elderly, you reduce all cardiovascular complications. But obviously, you have to make sure that you're not precipitating postural hypotension, you're not causing azotemia, etc. Now, what is the difference between achieving blood pressure goals or not achieving the blood pressure goals? And this is a very beautiful study. There are 4 lines of reference in this. One line is people who never develop hypertension, normal blood pressure. The other is people who have hypertension where the blood pressure goal is achieved. So either you are lucky not to develop hypertension, or if you develop hypertension, you make the blood pressure goal normal, your life expectancy is the same. Now you have a patient with undiagnosed hypertension or uncontrolled hypertension. So there is no difference between undiagnosed hypertension and uncontrolled hypertension. So the goal is when you diagnose hypertension, you should make it normal. Then only you are helping them. But otherwise, if you are leaving them, somebody, Dr. Tarabdar is here, other nephrologists are here, they see patients with 200 or 130, 200 or 120 every day. But if they treat and say that I have made your blood pressure 180 or 100, they are still at a high risk for cardiovascular disease. So, ladies and gentlemen, don't leave the patient in the middle of the road. All of you have come here either from your clinic or from your home. This was your destination. But nobody has left you in the middle. So that is the way it should be on the treatment of hypertension. I'm giving some therapeutic principles. Now, heart and kidney, they have a so-called hostile relationship. When you have cardiac involvement, there is cardiac hypertrophy, other complications. When you have chronic kidney disease, you have complications. And when you have both of them, then the complication rate is increased. In fact, I don't mind saying I'm a very strong supporter of nephrologists because we don't refer the patients to the nephrologist. I am not saying because Dr. Tarabdar is here. I say it all the time. We don't refer the patients to the nephrologist early on. We wait till they are stage 3 or stage 4. In fact, I was asking Dr. Tarabdar one question when patient sent me. His creatinine has gone from 1.09 to 1.23. 1.23, which usually does not shake up. He said it needs to be checked up. That is the way we should be. Early detection of chronic kidney disease is very, very important. And referral, if you want, you treat aggressively. But don't ignore these slight elevations of creatinine because they're dangerous. So, ladies and gentlemen, chronic kidney disease and cardiovascular disease are together in robbing the patient of his or her health. And some people believe that the heart of the matter is in the kidneys because it's a very pathogenic mechanism. Now, we treat high blood pressure. When you see a patient with hypertension in the office, you're not thinking about hypertension and encephalopathy. That's not what you're thinking about. You're thinking about preventing heart disease. And heart disease is caused by atherosclerosis. And these are all the, unfortunately, post-mortem aortas of individuals whose only diagnosis is hypertension. No smoking, no hyperlipidemia, no obesity, no diabetes. The only diagnosis they had is hypertension. So you see, hypertension causes atherosclerosis. In fact, much more than lipids. Now, I am going to show you so-called experiment of the nature. Experiment of the nature. That with that I can close the remark that hypertension causes atherosclerosis. And this experiment of the nature, cardiologists see few patients a year. Coarctation of the aorta. In coarctation of the aorta, the blood pressure is high above coarctation, but it is low or normal below coarctation. So what happens? There is atherosclerosis above coarctation, no atherosclerosis below coarctation. Ladies and gentlemen, as they say in a court case, I rest my case that high blood pressure causes atherosclerosis. Now, another thing that we seem to forget is we only think about coronary, carotid, renal, but peripheral vascular disease, the number one cause of peripheral vascular disease is hypertension. Look here, as the blood pressure increases, the peripheral arterial disease increases. We have to think about it. Somehow I wouldn't say we neglect it, but if somebody says some cramping or something, we don't pay that much attention, but just a reminder. Another complication of hypertension, now considered number one cause of cognitive dysfunction, is hypertension. Number one cause of cognitive dysfunction is hypertension. This is a study where patients with hypertension with low cognitive function were treated, and when they were treated effectively, the cognitive function improves. So if somebody says, I'm forgetting names, I'm doing few things, don't say chalta hai, chalta hai, chalta hai. Chalta nahi, chal nahi sakte. So you have to treat them, hoping that you will avoid cognitive dysfunction. If you want to call it Alzheimer's disease, I don't mind at all. You can call it anything you want. Now, coming to the treatment of hypertension. Why are we treating hypertension? What is the evidence we are treating hypertension? Ladies and gentlemen, we are treating hypertension because of one trial called Veterans Administration Cooperative Trial. One trial, VA cooperative trial done in 70s, where it showed patients, when you treat hypertension, you reduce cardiovascular events. First trial to show that when you lower the blood pressure, you decrease complications. You know what is the strangest thing about this study? This study will never be published now, if it was done. There were only 180 patients in each group. 180. Out of 180 in actively treated group, there were 30 deaths. And 180 in the placebo group, there was 80 deaths. So the statistical significance between 30 and 80 was very, very high. And that's how the paper was accepted. These days, nobody will accept studies which has 100 patients, 200 patients, 300 patients. One study from Hyderabad, somebody told me, somebody rejected it because it only had 600 patients. So what I'm trying to do is historically, how the treatment of hypertension is based on 360 patients, 360 patients, and it is remarkable. It is remarkable. Now, I will make few comments not in great detail, few comments on few classes of antihypertensive drugs. Beta blockers have been restored among the initial choices of the treatment of hypertension. They were not withdrawn, they were not cited, but it's come back. Because beta blockers have multiple cardiovascular protective effects. Particularly, it has been shown that beta blockers are quite useful among Indian patients. Among beta blockers, there are several choices, new generation, etc. One of the drugs that is, suddenly there is a so-called upending of bisoprolol in India, I have noticed. And one of the reasons could be it is a very, very highly cardioselective. Bisoprolol has been there for a long time, but there appears to be, I see patients, there appears to be an upsurge because of probably cardioselectivity. Now, let us see what happens if you control hypertension and you also control the heart rate. So the best prognosis is not just treatment of hypertension, this is treatment of hypertension, but if you treat hypertension, also lower the heart rate. Low blood pressure, normal heart rate. So the best prognosis is normal blood pressure and normal heart rate. But if you have normal blood pressure, but the heart rate is high, you don't get any benefit. And this is older times, I don't know if they still use the word double product. They used to use the word double product, but I think now it becomes, if I say that, they will think that I am antiquated. So, number of calcium blocking drugs, particularly in India, so many calcium blocking drugs, all of them quite effective. An ideal calcium blocking drug should be as effective as amlodipine, which means amlodipine is the gold standard. Any drug you bring in front of me should be as effective as amlodipine. But it should be free of amlodipine side effects, namely edema, tachycardia, and in some people it can cause proteinuria if it is given by itself. So a new CCB should be as effective as amlodipine, but should not have the side effects of amlodipine. That is the way you define. There are several new generation CCBs in India. One of them is azanidipine, that there are others also. It is highly selective for L channels, and therefore it appears to be quite effective without causing edema or without provoking proteinuria. So, as effective as amlodipine, but does not appear to cause edema or proteinuria, most likely. Efficacy, there is no difference between azanidipine and amlodipine. I know that sometimes people tell me, ye drug diya, BP nahi hua. You have to give an optimal dosage. Anytime you say the drug is effective or ineffective, you have to give an optimal dosage. And this is something that nephrologists would welcome. Unlike other CCBs, azanidipine appears to lower the proteinuria because it dilates both afferent and efferent arterioles. Now, let's turn to diuretics in the treatment of hypertension. They have all the guidelines since 1972 have included guidelines, diuretics in the guidelines since 1972. That is the only class of drugs that has been untouched by any guidelines, local, national, global, doesn't matter. Always diuretics because they're effective. From JNC1, I want to make one mention about JNC1, and all of us here should be proud of JNC1. The chairman of JNC1 passed away, was a person of Indian origin, Iqbal Krishan from Srinagar. And I knew him, he was much older to me. He was the first JNC1 chairman, which is very, very important, historical, and you should walk with pride because of that. diuretics lower the blood pressure by reducing peripheral vascular resistance. Because the word, the nomenclature, pharmacopoeia, classifies them as diuretics, but the fall in blood pressure is because of fall in peripheral vascular resistance. And I'll show you why. When you give a diuretic, systolic blood pressure goes down, diastolic blood pressure goes down. Initially, cardiac output, plasma volume go down, peripheral vascular resistance goes down. Ultimately, cardiac output and plasma volume become normal, ultimately. But the blood pressure remains controlled because of fall in peripheral vascular resistance. So, when you give a diuretic, the cardiac output and plasma volume ultimately become normal, but the blood pressure remains normal. So, the dominant mechanism of action of diuretics is fall in peripheral vascular resistance. This is a very important message. Because if you continue to have diuresis every day, you die, right? You can't survive with continued diuresis. So that's a very important point to make. Now, there has always been a discussion, debate, differentiation between diuretics. I have not included loop diuretics in this because they are not useful for uncomplicated hypertension. They might be useful for patients who have chronic kidney disease. There is a benzyl structure where COH is released, COOH is released, that makes chlorthalidone a longer acting diuretic because of its chemistry. Chemistry is something that we cannot ignore because sometimes we don't understand, but the chemistry defines how medicines work. It is the chemistry that is very, very important. Because of this, it has got a long acting duration. Now the question is, why is this drug now prominent but not 50 years ago? That is because we were using very high doses, myself included. 100 milligram, 200 milligram, makes no sense. These are what is called as veterinary doses. But now we have realized that was too high a dose. So we are now in an era of what is known as optimal dose, which is low dose. So the duration of action is different between the two drugs due to its pharmacological chemistry. One of the trials which has shown the benefits of chlorthalidone, the LDL trial, is systolic hypertension, the elderly program, where elderly patients who received chlorthalidone had significant reduction in stroke, which is the complication you want to avoid. And hypertension detection follow-up program, at that time they call it as stage 1 hypertension, again showed significant benefits. Multiple risk factor intervention trial, which is hydrochlorothiazide chlorthalidone comparison, has shown that chlorthalidone reduces the blood pressure much more than hydrochlorothiazide, and therefore there is a greater regression of LVH because of fall in blood pressure. Then of course the ALLHAT trial, which has 40,000 patients, has shown that in patients exposed to chlorthalidone, there was reduced incidence of heart failure. This is a study that I did in my formative years when I was recruited by Dr. Norman Kaplan. He called me to his chamber and said, nobody knows the difference between these two drugs. We will be the first ones to demonstrate if we can do this study. So we did the study using, at that time, very crude ambulatory blood pressure monitoring, very crude. People will laugh. But anyway, we showed that the blood pressure goes down much more for 24 hours with chlorthalidone and hydrochlorothiazide. At that time, we showed, although we used higher dose than what it is used. So in the SPRINT trial, one of the drugs in combination therapy was chlorthalidone. And these are the comments the investigators told me personally, that majority of patients in the SPRINT trial were on chlorthalidone, and Paul Welton, who is chairman of the guidelines committee, who is going to be the president of the World Hypertension Conference in Chennai in March. He said for blood pressure control, investigators were advised to select chlorthalidone. They were advised to select chlorthalidone. And one of the advantages of long-acting drugs, any long-acting drug, is that nighttime blood pressure should also go down. Because nocturnal hypertension is a major risk factor for heart disease and for chronic kidney disease, as Dr. Rajiv Agarwal has shown. Now, the final segment, the last segment, the final segment will be our discussion. The last segment of my thing is the two papers which have completely solidified the choice of diuretics in the treatment of hypertension. Two recent papers. One is in New England Journal of Medicine and other is in JAMA Cardiology. These two papers have completely changed forever our thinking about diuretics. Let me talk about these two trials and then I will conclude. This is the first trial that has compared chlorthalidone to hydrochlorothiazide head to head. All the previous trials have put the data side by side, but this is head to head. Chlorthalidone or hydrochlorothiazide, and patients were followed for approximately 2.5 years. So when they followed patients for 2.5 years, they found that there was no difference in terms of the outcome. Chlorthalidone dose was half of hydrochlorothiazide. So there was no difference. And this is the same thing showing that there was no difference in the head-to-head trial. In patients who had pre-existing cardiovascular disease, heart disease, peripheral vascular disease, chlorthalidone was better than hydrochlorothiazide. So the main group, no difference. But if you tease them out to patients with pre-existing cardiovascular disease, then patients who are on chlorthalidone did much better. So that's what the main paper said. But what they did not mention is not that they deliberately, but they did not mention patients who were on hydrochlorothiazide were for a longer duration of treatment. Whereas chlorthalidone was started in the middle and they were on a short duration of treatment. Very interesting. One drug for a long time, another drug for a short time, similar outcomes. So that night, actually I called one of the investigators when it was published. I know them. I said, you missed a major thing. The duration of treatment with chlorthalidone was shorter than hydrochlorothiazide, which means you could have changed the conclusion of the paper, saying that short-term exposure to chlorthalidone is as good as long-term exposure to hydrochlorothiazide. And they agreed. They said, it's not deliberate. You know, how many points can you cover in any paper anyway? So, the conclusions of this salient conclusions were, chlorthalidone at low dose and hydrochlorothiazide at full dose are equally effective for blood pressure control. Similar outcomes except in one subgroup. But in India, I don't think we use hydrochlorothiazide 25 milligram. I don't think so. If I'm wrong, please correct me during discussion. But we use low dose chlorthalidone, that's for sure. Now, one of the investigators who was the author of this paper, on the phone, not in an email or anything, on the phone, and I told him that I'm going to quote him. When the paper was published, December 31st, 2022, I spoke to him on the phone, and he told me they have similar outcomes and it does not change my clinical practice. Although they said that both drugs are similar, but he said, I have no doubt chlorthalidone is better than hydrochlorothiazide. Sometimes some of the authors, if you talk to them personally, you really know the ultimate truth, what it is. Not deliberate, but there is always, human beings are a very peculiar set of animals. Now, the subgroup analysis was published in JAMA Cardiology. That's all. Same thing, they published in JAMA Cardiology, which is a very high impact journal. The blood pressure was very similar between chlorthalidone and hydrochlorothiazide. First time head-to-head comparison. What they have shown is that outcomes, negative outcomes, were lower in chlorthalidone group, probably driven by congestive heart failure. Usually all complications are driven by congestive heart failure. So what sub-analysis shows, they had fewer patients with heart failure compared to hydrochlorothiazide. When they looked at patients with hypokalemia, it was non-significant, 6.2, 6.8. There was not, statistically it was not significant. And when they looked at acute MI, it was lower in chlorthalidone group. And this one, this cancer deaths reduced, that is very peculiar finding. I don't know what to say about it. We'll leave it like that. So they looked at the adverse events, hyponatremia, hypokalemia, there was no difference. So adverse effects, hyponatremia, hypokalemia, there was no difference. So the conclusion was, of this paper, was chlorthalidone may be associated with reduced adverse cardiovascular events and non-cancer deaths compared to hydrochlorothiazide. That was the conclusion of the same main paper but sub-analysis. So the doses were pharmacologically comparable, and the first and only trial ever to compare them head to head. Only trial. I don't think it will be done again because these are not, and nobody wants to do it. Now, as far as India is concerned, our medical group is here and they were instrumental in the study. So looking at low dose chlorthalidone was a little bit more effective than hydrochlorothiazide. So that's what it is. It's a very, very important finding. And one of the things that I noted in the literature is that the pulse wave velocity, namely, which is pulse wave velocity, if it is high, that means the arteries are lost their elasticity. The pulse wave velocity has gone down significantly with chlorthalidone compared to hydrochlorothiazide. So it might have an effect on the structure. Pulse wave velocity, it is a prognostic factor. You don't have to do it, but it's a prognostic factor. So ladies and gentlemen, Mr. Chairman and wonderful panelists and the organizers and the audience, let me conclude by recapping few things that I have done. In the beginning, I have given you the blood pressure levels, how we have come, what is normal over 100 years. Then I have shown you that high blood pressure is the overwhelming cause for atherosclerosis. Then I showed you how South Asians or Indians are characterized as by various organizations a high-risk group. So we have to take it seriously. Then I covered some aspects of beta blockers, some aspects of CCBs, nothing new on ACE inhibitors to the best of my knowledge, nothing new. And few things about diuretics because these trials are new, very new. So my former colleague, late Dr. Kaplan, has written an editorial once upon a time that chlorthalidone versus hydrochlorothiazide, a tale of tortoise and rabbit. So he concluded that tortoise ultimately won the race. That's what he said. Very, very powerful editorial. Then the former president of American Society of Hypertension, Dr. Dominic Sika, has also written an editorial whether it has always been the best type of diuretic. Very powerful editorial. And recently, I spoke to Dr. Rajiv Agarwal, who did a lot of work on CKD and chlorthalidone. And recently, December 27th, I spoke to him. And he told me by text message, this is the text message he gave me, and I told him that I'm going to quote him. He said, quote me. So I always quote. So he told me that it lowers the blood pressure much more than renal denervation. So I have given you from Norman Kaplan, don't take my word for it, Dominic Sika, and now Rajiv Agarwal. So we can conclude this session that the original controversy or debate should not have existed at all, like other debates. And there is a Latin word which I like very much called imprimis, means in the first place. So ladies and gentlemen, imprimis, this debate that we had for 40, 50 years was not worth having it in the first place. So with those remarks, offering my respects and salutations to all of you, I'll conclude and thank you very much for your attention. Those are the data I have shown. Those are the data I have shown that in patients with pre-existing cardiovascular disease, there was a significant, very significant benefit. Now the question will be, Dr. Ram, what do you mean by pre-existing disease? We don't do treadmill in every patient who comes to hypertension. We don't do coronary scores on every patient. Many people have pre-existing disease until you discover it, right? So the only way that you're in an accident is when it happens. You will never know that you're going to be in an accident until it happens. So did I clarify? Okay, all right. I think we can conclude? Okay.
Thank you, Dr. Ram, for the excellent presentation on hypertension management. Next, I would like to call upon stage Professor Dr. Partha S. Banerjee for the summarizing and the key aspects from Dr. Ram's session, please.
So good evening, everybody. Initially, we must thanks to Professor Venkatram for a wonderful expression of the whole subject in a very decent manner, starting from the definition, the atherosclerosis part, the target organ damage and management, and lastly on the selection of the diuretic. And we all know that hypertension is a very, very common problem and we come across in our day-to-day life. So what I feel that the most important is the early diagnosis, because unless you can diagnose it early, you may lose the bus, because once the organ damage starts, then the complication also progressively increased. So that is why the most important is the early diagnosis, especially the high-risk individuals like the younger patient, obese patient, with the family history of hypertension. So these are all very important factors. Another important factor is the obstructive sleep apnea. This is a very important cause, particularly in the young patient below the age of 40 years who are obese. So we should not miss that diagnosis at the same time. And other end is a very elderly patient, where often the diagnosis of hypertension is done, but the pressure is not well controlled, and often we miss to auscultate the renal bruit, because atherosclerosis leading to renal artery stenosis in very elderly subject is a very missed cause of elderly hypertension, which later on is said to be resistant, but finally comes to be atherosclerotic renal artery stenosis. So that has to be also kept in mind. And in younger patient, what Dr. Ram has already said about the coarctation of the aorta. This is also very important. So you feel the all pulses peripherally. That is very important. At the same time, you also feel the carotid also, because hypertension often associated with carotid artery stenosis or atherosclerosis and a plaque, which can lead to repeated attacks of TIA or the cerebrovascular event. So I feel that the early diagnosis, then the investigation, whatever you need, that you already know, and the renal profile estimation is very important, because once the renal damage starts, then the thing aggravates and it becomes really a challenge to control the hypertension. The patient who are having CKD leading to resistant hypertension, often it is called, and in that case, I think Dr. Tarodari is here, he will explain in detail. Now my point is that once you diagnose as Dr. Ram has said elaborately, the choice of the drugs, and we all know the first line of drugs means which reduce the cardiovascular events and death. And these are the drugs are called to be the most important drugs, as has been already said, that the ARB or ACE inhibitor, calcium channel blocker like amlodipine, and the diuretic. And the beta blockers should not be neglected. This is another point, because the earlier recommendation was that beta blockers should be on the 4th place, but nowadays we have seen that most of the patients do have associated the cardiovascular disease. And the most important drug in that situation is, of course, beta blockers, selective beta blockers like metoprolol or bisoprolol. And you must not neglect to underuse the beta blocker in the appropriate position. Because once you meet many patients do die because of the sudden acute coronary syndrome or heart failure. And you all know that beta blocker has a strong effect on the cardiovascular protection, and pulse rate, as he has already explained, you are controlling the blood pressure, but the pulse rate is very high. So control of the pulse rate is very important. Unless you control it, the pulse, and there remains again increased incidence of the cardiovascular events. So combination is a choice at the present time of management of the hypertension, because since it has got multiple pathogenesis in the development, is monotherapy may not be as effective like a combination therapy in a single pill formation. And that will also increase your compliance to manage the hypertension. So you try to give the combination drug, particularly when the patient comes with stage 2 or stage 3 hypertension, especially when it is associated with target organ damage. And the JNC7 already said earlier that if you give a combination therapy, one of the drugs should be a diuretic, because the 2 non-diuretic or 3 non-diuretic drugs may not be enough to control the hypertension to the optimum level. And also do not forget to remember about the spironolactone, which is often a very wonderful drug when you are not being able to control the hypertension with 3 drugs, and the 4th may be the spironolactone. And if the patient can tolerate it, then you can switch over to eplerenone. So refractory hypertension is often a misnomer, because it is often because of the failure of the compliance. So when the patient is coming to you without control hypertension, even after the addition of the 3 more drugs, you must see what is the compliance of the patient. Is he taking the drug correct dose and in combination whatever you have advised? Is he taking a diuretic? Is he taking extra salt? Is he taking another drug that can increase the hypertension like corticosteroids or NSAID? So these are all very important tips when you come across a resistant hypertension. As I already told, don't forget to auscultate the flank of the abdomen in a very elderly patient, not to miss a diagnosis of the atherosclerotic renal artery stenosis. And Dr. Ram has already said the role of clothalidone even in the reduction as compared to better than the sympathetic renal nerve denervation. So that is already not established therapy by any large randomized trial. So when this is established that chlorthalidone is a better drug, so why not to use chlorthalidone? Now, as regards the dyselectrolytemia, I have a question to Dr. Ram, whether the trial which was shown about that there is no difference in the dyselectrolytemia between the chlorthalidone and the thiazide, is all the Asian populations who are residing in the tropical country are included in the trial or not? Because the weather is hot in Asian countries, particularly in South Asia. So we have to understand that point also, that this dyselectrolytemia, is it less in the Caucasian, like in Europe or North America? So that is a point has to be clarified. So I think the first is early diagnosis, then to find out any target organ damage, and then to appropriately formulate the drug, preferably in a single dose formulation to increase the compliance, and also see whether patient is adhering to your treatment before you declare it as a resistant hypertension. And once complication develops, then you are at a great discomfort to manage the patient, like the CKD, like other complications, like a CVA, when the patient loses the power of the limbs. So that is why early diagnosis, early management with the appropriate drug, and compliance to the management, whatever you have given, are the most important part as regards the total management of hypertension. Thank you.
As usual, Dr. Ram at his best, and you have heard him, and I think you should agree with him. There are other panelists also. They will speak at length. But at each point of time, each and every speaker has to raise the issue of kidneys. And that's the reason I'm here, to share some of the subtle scenarios where the kidneys may make you forced to change your decision. What are the ways, while you manage excuse me, a case of hypertension, kidney, the renal function, and everything may change your decision. I'll raise some of the issues. As for example, firstly, Dr. Ram has highlighted the issue of chlorthalidone. Even other thiazide diuretics as well. But when you consider the GFR, you will find that the decision changes depending on the GFR. Managing hypertension in chronic kidney disease patients is unique because it's not a static sort of management. It is a dynamic sort of management. As the GFR changes, your decision also has to change. As for example, Dr. Ram has highlighted the issue of chlorthalidone in the trial by Rajiv, CLICK trial. In CLICK trial also, he has shown that chlorthalidone is effective up to a GFR of around 23 or so. Below that, chlorthalidone is not effective. Even the conventional thiazides are not effective up to 23. It is more than that, maybe 30, 35, like that. Chlorthalidone is better in that sense, that it is effective till a GFR of 23, but below 23 GFR, you have to take recourse to some other high-ceiling diuretics like furosemide or torsemide. So this is very important. Not only that, as volume is a very important issue in the management of hypertension, particularly in CKD patients, in falling GFR, if you do not give significant credence to volume, then actually you are losing the fight. So in that case, if you continue to confine yourself to thiazide diuretics at a relatively lower GFR, you have problem. Spironolactone, Professor Banerjee has said, but once again, conventionally speaking, an MRA is contraindicated below a GFR of 40.
Now, there are exceptions, but conventionally speaking, MRAs are contraindicated when the GFR falls below 40. So, at a GFR, when the GFR is less than 20 or 15, what should be your choice? As I've already said, then you have to think of high ceiling diuretics and one thiazide-like diuretic, that is metronidazole, because metronidazole is effective even at a GFR of less than 25, but please be cautious that metronidazole may cause significant dyselectrolytemia and volume depletion very rapidly. So it is preferable to give metronidazole in combination with a high ceiling diuretic. We call it sequential diuretic therapy. We prefer, as for example, we give a very low dose metronidazole, 2.5 or something like that, about 1 hour before a high ceiling diuretic, say torsemide, because torsemide has a relatively longer duration of action. And because there is another additional point, because these two diuretics, they act at two different sides of the nephron. And that's the reason why we call them sequential diuretic therapy, because metronidazole goes at the front, it does its action, and then it allows the high ceiling diuretic which is following metronidazole. So the sequential diuretic in a patient who has resistant overload, giving metronidazole followed by a high ceiling diuretic like torsemide is effective in resistant overload and resistant hypertension, both. So this is another area regarding diuretic therapy in the context of chronic kidney disease. Coming to the other issues that have been highlighted, like beta blockers. Beta blockers, when we nephrologists select beta blockers, we keep in mind two things. One is whether this beta blocker is being excreted through the kidneys. If it is being excreted, it tends to get accumulated and bradycardia may be more. More importantly, in a CKD patient, when we are selecting some beta blockers like propranolol or labetalol, they can cause dangerous, life-threatening hyperkalemia. And when a patient, excuse me, when a patient comes to a nephrologist or even a physician with say, bradycardia, then the question comes, is this bradycardia because of a beta blocker? Is this bradycardia because of hyperkalemia for some other reason also? Suppose the patient is not on beta blocker, then also you may have hyperkalemia like spironolactone, even in the newer MRAs. Hyperkalemia, the clinical manifestation of hyperkalemia is bradycardia. Sometimes when I was in PG hospital, we used to see a lot of snake bite patients. Patient admitted. Next day, I go for the rounds. In the morning, when we examine the patients, even the blood biochemistry is not available. Put your hand on the pulse of the patient, and if you find the patient has bradycardia, snake bite, bradycardia, hyperkalemia, you take the patient for dialysis, invariably the potassium report will come as 6.5 or 7. Because bradycardia is a clinical manifestation of hyperkalemia in the context of oliguria, AKI, or CKD with AKI. So when a patient has renal dysfunction, and if the patient has bradycardia, other than beta blockers, you also have to think of hyperkalemia and some of the beta blockers like labetalol and propranolol. So what I suggest is, whenever we manage patients, we should keep our management more or less individualized. If we go by the guidelines, sometimes we are on the wrong foot. I think Professor Banerjee has raised a very vital and pertinent issue. That issue is so-called, quote-unquote, resistant hypertension. Resistant hypertension, theoretically, there are various definitions. The blood pressure is not controlled with 3 antihypertensive drugs, or even if it is controlled with 4 antihypertensive drugs, it is resistant hypertension. There is a subgroup called refractory hypertension, and so on. But if we consider our experience, the most common cause of resistant hypertension in Indian context is AP or ATRH, that is apparent treatment-resistant hypertension. A recent study has shown that if you start antihypertensive in, say, 100 patients, at 1 year you will find 50% of these patients, out of 100, 50 patients are not taking the medicines properly. And that is the most common cause of resistant hypertension. It is not that the patient is being treated and the patient is not responding to the antihypertensive agent. But the most common cause is the patient is not taking medicines properly. That is one of very important cause. And there are various reasons, the side effect of medicines. There are a lot of advices, quarks and all, they 120, 80 blood pressure, well, you can stop antihypertensive. That is one thing. Cost of the medicine, timing of the medicine. There is a concept of polypill nowadays because of this concept. In CKD patients, there is a tendency towards night rising blood pressure. As the blood pressure tends to rise at night, so there is also a suggestion that you can give the antihypertensives together at night, or you can split the diuretic in the morning or the rest of the medicines, particularly the RAS blockers in the evening. Splitting these, and the concept is described as chronotherapy, though there are some controversies about the pros and cons of chronotherapy. That's a different issue. But there are so many things in when you manage a CKD patient, because CKD patients are not the usual hypertensive population that the non-CKD group of population. And while managing patients, we nephrologists address these patients from a different outlook, because there are so many things, GFR, hyperkalemia, other metabolic issues, taking together everything we usually manage. And Professor Banerjee has rightly pointed out that some of the medicines can also cause a rise of blood pressure, particularly in CKD patients. One of them is erythropoietin. I have seen prescriptions, blood pressure uncontrolled, yet the patient is getting high dose erythropoietin, blood pressure is shooting up. And as the blood pressure is shooting up, the renal function also deteriorates further. That is one. Second is, now there is a fashion, without checking even the bicarb level, patients are being pumped with sodium bicarbonate. My PGT, only yesterday I got a message from my postgraduate student that his thesis has been accepted for DNB. And his work was nothing but to address exactly how much population of our CKD population has really have acidosis. And the result is astounding. Because our diet is relatively less rich in animal protein, we have very few patients who have true acidosis. So pumping these patients with sodium bicarbonate may be problematic, in the sense there will be sodium retention and blood pressure may shoot up. So without checking bicarbonate, indiscriminate use of sodium bicarbonate should be avoided. So there are some of these issues I tried to highlight. These are practical issues that what we face while managing hypertension in CKD population. And the rest of the things, you must be having a lot of problems. You can raise these issues, we can discuss across the table. Thank you very much.
Good evening and thank you, and we all are here because of IPCA, the House of Diuretic. So I'll just catch the line which Dr. Norman Kaplan told, that the hare and the tortoise, and the hare here is the industry which promoted chlorothiazide, and the tortoise was CTD, or the chlorothalidone, which was the nephrologist which kept holding on to the chlorothalidone. And how much did the patient suffer? We need to have more trials with these low doses of chlorothalidone versus chlorothiazide, that the patient did suffer for the last 50, 60 years of being over promotion of chlorothiazide or chlorothalidone. And that's all, and we all have heard from the different speakers. I think that's all from my side. Thank you.
So thank you very much, Dr. Ram, for coming all the way. So European Society of Cardiology 2024 guideline, I feel, is the latest guideline, which is good in the sense that it has clarified many of the issues, clear-cut recommendation. Now, as per this ESC 2024 guideline, there is nothing called normal blood pressure. It is either not elevated, elevated, or hypertension. So I would take the opinion of Dr. Ram because there is some logic behind this new category of elevated blood pressure. What does it mean? Systolic blood pressure of 120 to 139. Diastolic blood pressure of 70 to 89. So they are considered to be normal blood pressure, office measurement I am talking. If you are measuring the home monitoring or ambulatory blood pressure monitoring, it will be around 5 millimeter less. Now it has been shown that in this elevated blood pressure, you can still have cardiovascular events. Now there can be debate whether these cardiovascular events are really due to high blood pressure or that is due to something else. It may be undetected dyslipidemia, blood sugar, etc., or some genetic factor. But in this group of patients, probably if you have end organ damage, features of end organ damage, probably there is some role of monotherapy even in this era. And I'd like to have the opinion of Dr. Ram, how we are going to face this issue of elevated blood pressure and what can be our approach to this elevated blood pressure patient, because there had been too many of controversial statements in this current European Society of Cardiology guideline. Thank you very much.
The comments of all the panelists are appreciated. They're on target and they're appropriate. Now, the European Society of Cardiology guidelines are somewhat controversial or critical. The reason is, for the first time, European Society of Cardiology has separated itself from European Society of Hypertension, which has never happened before. All the European guidelines were together. But for some reason, European Society of Cardiology, I don't know the reasons, I don't want to speculate, they wanted to go the other way themselves. So they had a group of people who are very good in their subject, but who never had that much experience as hypertension researchers. I say it with respect. So they had to select some people who are interested in writing a document on the basis of something. And this somewhat controversial guidelines, because as Dr. Pandey has suggested, that they don't call it hypertension. They call it elevated blood pressure. But elevated blood pressure is a little bit more of a layman's term than hypertension. They meant well, but that is not the way to define, in my opinion. I think they could have said degrees of hypertension, stages of hypertension, but elevated and non-elevated blood pressure divides the world into two categories, and there is no definite line. So I wrote a letter which was not published, in fact rejected, which happens, is I said next time then we don't call anybody as diabetic, we call them elevated blood sugar. Then I said we don't call anybody as having hyperlipidemia, we call them elevated lipids. We don't call them anybody as obese, we call them elevated body weight. I said this concept is very, very peculiar and requires closer examination. And I say it respectfully.
Thank you. I think we are going to close the session very soon. But before that, there are some questions from the audience. And before we address the questions to Dr. Venkatram, Dr. Banerjee, Dr. Pandey, and others, just a very simple way to remember that the hypertension has changed from 120/80 to 140/90. We all read during our medicine MBBS days and later on that high blood pressure beyond 140/90 is hypertension. Blood pressure 120/80 is a normotension. The new sort of the marker of 130/80 is called elevated blood pressure. Do you know the reason? It's a layman's language, as Dr. Venkatram said. The reason is that now we, the medical community, identified that hypertension is a public health hazard, like smoking. So when you think that this is a public health problem, then you address in a language which is understandable for the public, not for the clinician, not for the doctors. That is the reason why Dr. Ram said that hypertension is going to be elevated blood pressure, hyperglycemia is going to be elevated blood sugar, hyperlipidemia is going to be elevated fat or elevated lipid. So that is a very unique way. And the other reason is that it has been shown, the very nice slide, we took nearly 100 years, try to imagine, from 1935 till 2025, 90 years we took to understand that somebody who is having 130/80 blood pressure eventually can get complications of hypertension, like hypertensive heart disease, like stroke, like heart failure, like aggressive atherosclerosis leading into ischemic heart disease, cardiac arrhythmia like atrial fibrillation, renal problem, and peripheral vascular disease, and retinal problem. But this is what is medicine. It takes 90 years time, isn't it? From 20, did you see the slide? 1935 it was recognized, in 2025, now we know that this is very important, we have to address. The reason is that 130/80 blood pressure going on slowly. That is the statement made by Dr. Ram is so meaningful. He said that mild hypertension is actually a malignant hypertension. Isn't it? Because we think it is mild, so we ignore it. Oh, many of us, many of our colleagues in their clinical practice, patient comes, blood pressure 130/84, oh, don't worry, nothing to be worried about. But that 130/85 eventually is going to cause left ventricular hypertrophy, coronary artery disease, heart failure, and cardiac arrhythmia. So that is a wake-up call for us. So that is the reason why these definitions are getting changed every 4 years. With that introduction, some questions we'll quickly address, and then we're going to close the session. I think 2 more. I think we should stop it, because otherwise this will be more of paper than us. The first question, status of nebivolol as beta blocker. I think this was raised by, beta blocker was raised by Dr. Pandey, or no? Or I think Dr. Pandey, you raised beta blocker, right? Who raised beta blocker? Now somebody, I think, out of these 4. No. Who commented beta blocker? I think Dr. Abhijit Taraptar. You said about renal failure. Yeah, the hyperkalemia beta blocker. Status of nebivolol as a beta blocker in comparison to bisoprolol for reduction of blood pressure. I think that goes to Venkatram. Dr. Ram.
Anybody wants to comment?
Okay. That is yours. That question is put to you. Question is to you.
I don't know, but I still want somebody to comment.
Okay.
I need some help.
Right.
Labetalol is characterized as an alpha beta blocker. But when you take it by mouth, oral, which is the most common prime. Nebivolol, okay, I'm sorry.
Nebivolol.
Yeah, okay, that's a good question. It's hard to, there are no head-to-head trials between nebivolol and bisoprolol. Actually, nebivolol is a newer molecule compared to bisoprolol. And there is, nebivolol pharmacologically appears to have an effect on nitric oxide. Studies have shown that it increases the nitric oxide, so which is a beneficial effect. There is only one outcome trial with nebivolol called Seniors, which was done in elderly patients where it appears to be superior. So the fair response is nebivolol and bisoprolol, despite the fundamental molecular different mechanisms of action, they probably have similar cardiovascular effects. And there are no head-to-head comparison. I would not comment whether it is superior. If somebody is taking, let us say, nebivolol, I don't see a compelling reason to switch them to bisoprolol or reverse. I don't see it, unless the patient has some complaints. Sometimes patients complain which we cannot explain, but we also are human beings. If they complain something, we try to change to see if it helps. So that's my comment.
Excellent. I think that nebivolol is basically a nitric oxide release. So that is an advantage. But remember that particular statement made by Dr. Taraptar, that beta blocker can actually cause hyperkalemia. So somebody on, for example, nowadays people are even thinking of using ARNI as a drug for sort of hypertension. So hyperkalemia, if you have multiple drugs like MRA or ACE inhibitors or sartans, and then on the top of that beta blocker, and the patient has got creatinine somewhere 1.2 or something 1.27, and then try to remember that this patient may actually get hyperkalemia, which will eventually cause bradycardia. You think this is because of beta blocker, you are happy, but it's not, it is hyperkalemia. That is one thing, very, very essentially, very important for us to understand. Just in other way around, I'm sure you all know that when you take a sort of nebulizer during acute episodes of COPD or asthma, you take nebulizer, isn't it? It causes hypokalemia, isn't it? So that is exactly the other way around, because the mechanism is different. Next question to Dr. Tarabdar by Dr. Ashish. The previous question was from Dr. Gautam Banerjee. Long continued treatment with chlorthalidone has got any special beneficial effect on kidney? Dr. Tarabdar.
No study has been done in this regard whether it has any beneficial effect. But once again, I go back to the CLIC trial. In CLIC trial, they have mentioned that there is a reversible, quote unquote, reversible deterioration of renal function. The GFR drops, the creatinine rises. My question is, we are treating a group of hypertensive patients. Are we going to stop the treatment? If not, then if the creatinine rises, if the GFR falls, it will be irreversible. Because by reversible, they mean that as you stop it, it will be reversed. But the question is, as it was not a long-term trial, we don't know exactly what exactly the reversibility means. Is it so that with time, as Professor Venkatram was telling, with time the GFR normalizes, as it was a short-term trial? We don't know the real answer. For that, we have to wait.
Thank you. Yeah. Dr. Banerjee.
So I have a question for Dr. Tarabdar. Now, as cardiologists, we often use SGLT2 inhibitor because we all know that it gives a tremendous protection in the cardiovascular disease or the outcome. But what is your comment about using this SGLT2 inhibitor in a CKD where the GFR is, say, more than 20 ml per minute? Now, do you routinely use it or not for cardiovascular as well as nephroprotection?
Okay. So SGLT2 inhibitor, as of now, we nephrologists are yet to decide about SGLT2 inhibitors. Not me, I mean, worldwide. If you see the nephrology articles, you'll find that there are two sets of opinion. Let me share with him exactly how I look at it. Mostly SGLT2 inhibitors are not started by nephrologists. They are started by cardiologists, started by diabetologists, and initiated by physicians. So when the patient comes to me, if I find that with SGLT2 inhibitor, the volume correction is good, diabetes control is good, blood pressure control is good, and the serum creatinine also has improved or stabilized, then I'll continue with it. But let me share with you, about 1 in 3 patients, they have some or the other problem like urinary tract infection, genital fungal infection, and so on. So while selecting SGLT2 inhibitors, I think barring some of my students, most of you are non-nephrologists. So when we select, rather you select an SGLT2 inhibitor, please do take a few precautions. As for example, if the patient is an elderly male patient where the ultrasound shows there is enlarged prostate, or because of some other reason there is stasis, say bladder outflow obstruction or renal stone, there is stasis anywhere in the urinary tract, please remember that stasis with infection. Yes, glucosuria will invite infections. So it is always prudent to check it. This is one. Second, in critical care setting, if the patient has got sepsis, hypotension, please don't initiate SGLT2 inhibitor. Third, Suppose a patient, diabetic patient, has got ketosis, please don't initiate SGLT2 inhibitor. In type 1 diabetes, use of SGLT2 inhibitors not yet standardized, please don't initiate SGLT2 inhibitors. But once again, I reiterate that regarding SGLT2 inhibitors, we still have some problems. I think in the next 5 or 10 years, we'll be able to give you the final answer.
Thank you, Dr. Tarot. By the way,
Sir,
I think
may
you
I
all know
please-
that empagliflozin is going out of patent. All the industries are making a long queue outside your clinical offices. So be careful.
Sir,
So, next
sir,
question to
please,
Dr.
may I interrupt, sir? One moment, sir. Can I interrupt a bit? I've got
sure.
a question to Dr. Tarofdar. Can I please interrupt?
Yeah, please.
My question is, you were talking about beta blockers causing hypokalemia, right?
No, hyperkalemia.
Hyper.
Hyperkalemia.
Yes. Now the point is nebivolol, it must be included there, is it?
No, nebivolol, I told you
Uh-huh.
that the 2 beta blockers which are notorious to cause hyperkalemia,
Yes, you told me.
are not bisoprolol,
Labetalol.
labetalol and propranolol.
Exactly.
These 2 beta blockers are notorious to cause hyperkalemia.
Uh-huh.
Only recently, in those patients and non-CKD patients, there is some apprehension that some beta blockers may cause hypokalemia. It came in the paper. So I only wish to share with you, in a patient who has compromised GFR and say baseline potassium is say between 5 and 5.5, I think you should think twice. Particularly, you see, many patients who have migraine are being prescribed by neurologists with propranolol. Many patients in obstetrical situations are being prescribed labetalol. Time and again, we have gone to see the patient and we find the potassium is 6.57 because of those beta blockers.
Now,
That's the note of caution.
Now, why I ask this question is that one of my patients is taking nebivolol for, say, 25 years.
Nebivolol, I didn't say it causes hyperkalemia.
No, I'm telling you what has happened. After 25 years, she developed hypokalemia. Could it be the reason?
Yes, I told you that there are reports of hypokalemia recently.
Okay.
There are
But then,
lot of these.
but now rectified.
Yeah, but nebivolol is relatively safe, actually, unlike
Okay,
labetalol.
thank you very much.
Coming back to Dr. This question from Dr. Ashish Bhattacharya again to Dr. Arindam Pandey. Role of chlorthalidone in heart failure with preserved ejection fraction. You wrote non-hypertension. Any particular? Did you anything, Dr. Ashish Bhattacharya? You wrote non-hypertension. Arindam, you can take the microphone.
Yes. So preserved ejection fraction is a different ball game. As of now, if we go by the guideline and recommendation, class 1 recommendation are diuretic, but they have clearly mentioned it is the loop diuretic if the patient is in a volume overloaded state. Rest of the diuretics are not mentioned here. Now, other class of molecule which has class 1 recommendation in preserved ejection fraction heart failure are SGLT2 inhibitor. Again, 2 names are clearly mentioned. Number 1, empagliflozin. Number 2, dapagliflozin. Both have good quality randomized control trial in favor of it. Now, third group of molecule which has effect in preserved ejection fraction and recommended are ARNI. They are class 2B recommended because the overall trial data with ARNI, known as Paragon trial, was a negative trial, but in the sub-analysis in women and ejection fraction between 40 to 55, there was clear-cut statistical benefit. Fourth group of molecules in preserved ejection fraction heart failure are mineralocorticoid receptor antagonist. There was a big trial known as TopCat trial. TopCat trial, overall the data was negative, but many people say it was the geographical variation and differences in the population which made the trial overall negative, because the participant from Georgia and Russia, they were actually not very meticulously followed up. So probably that resulted in overall negative outcome of the spironolactone in preserved ejection fraction heart failure. But still we use it. And more so, recently one big trial known as FINARTS trial. FINARTS trial was done with finerenone. That is a kidney molecule. Dr. Tarabdar is there. I know he is not a very big, favorite person for this finerenone, but Usually, as of now, we had data with finerenone in diabetic CKD with a doses of 10 and 20 milligram. That too with a very meticulous monitoring of the potassium. But this preserved ejection fraction data of finerenone, the trial was done with 40 milligram of finerenone from the very beginning. And the result was actually positive. So probably in recent future, finerenone may come into the overall recommendation of treatment of preserved ejection fraction heart failure.
Correct.
Now someone asked me clothalidone. As of now, there is no recommendation, but if the patient is having heart failure because of hypertension, then this molecule will be effective because reducing the comorbidity actually helps in all the patients of heart failure. I just want to mention one last point. Obesity associated preserved ejection fraction heart failure, you can use injectable semaglutide, which has come up with a positive trial. Thank you.
Excellent. Very well
just-
said. And as you said, this is the call.
Dr. Chakravarti,
Yeah,
one
say.
point. So what the question was CTD, the chlorthalidone in heart failure. So if there is a hypertension, the choice could be chlorthalidone because as Dr. Ram showed in his slide, that the cardiovascular benefit were mainly driven by less heart failure. So not in any group particularly, but if you are using as an antihypertensive, the benefits were driven that there were less heart failure in patients who were receiving chlorthalidone versus chlorthalidone.
True. It is basically, Dr. Banerjee, you wanted to say something? You want to say something? You want to add anything? Dr. Banerjee, you want to add something?
So, what Dr. Tarun was telling about the choice of beta blockers, because he is very scared about the development of the hyperkalemia, particularly labetalol and
Propranolol.
Inderal or propranolol. The point is, majority of the patients do die of the cardiovascular events, having CKD. And we have been referred so many cases with angina and ACS, all this type. Now, we have experienced, I will take his opinion as well, that the bisoprolol, which has got the major sympathetic selectivity, causing hypotension or reduction of the blood pressure as well as the control of tachycardia, because the CKD patients do have anemia, and that may lead to anemia, tachycardia as well. And we have seen a significant effect on the reduction of angina as well as the outcome we have also seen. So, do you have any, objection to use of bisoprolol when the patient has the evidence of having ongoing angina?
No, I think
in
he
reducing
never
the
objected to beta blocker as such. He just is a word of caution.
Okay, thank you once again, Professor Banerjee. I would like to share with you that beta blockers are not contraindicated in CKD patients.
Correct.
Firstly, as Professor Banerjee has said, that most of the patients of CKD, they die of cardiovascular events. Agreed. But interestingly, it's not coronary artery events. It is heart failure and sudden cardiac death. These are the two common, statistically, these are the two common causes instead of coronary artery disease. This is one. Secondly, coming to beta blocker, particularly bisoprolol. Bisoprolol specifically is good in those patients who have asthma and COPD. That is the area where bisoprolol is the preferred beta blocker. In those patients who have bronchospasm, asthma, and COPD, bisoprolol is the drug of choice so far as beta blocker is concerned.
Correct.
We nephrologists have no reservation about beta blockers,
Right.
bisoprolol.
Every good thing has to end, but before we end, we are going to have last two questions to be answered by Dr. Ram. The first question from Dr. Siddhartha Bandyopadhyay. Dr. Ram, indapamide, what is your comment about indapamide in treatment of hypertension?
This question always comes up and should come up, always. Indapamide classified as a diuretic, but a significant effect appears to be calcium channel blockade. But pharmacopoeia, however they define, it is classified as a diuretic. The number of trials with indapamide in only hypertension, I'm not talking about Europa, other patients where you have coronary artery disease, pure hypertension are very few trials. But the trials which have used indapamide as a component like high VAT, etc., have shown that it is beneficial. It is beneficial. So there is no comparative between
Data.
all these three diuretics, but the number of clinical trials with indamapamide in hypertension are fewer than other things. It doesn't make it inferior or anything,
Right.
but we have to be aware of it.
And the last question to you, sir, just quick, because people are already
Initial
10,
summary
nearly
of the
10:30.
case. Now, what is your opinion about the effect on this electrolytemia between the two groups of diabetic? Because the Caucasian as well as the...
No, I can't tell. I wanted to, I tried to tease my brain when you mentioned. I can't tell. I can't tell, really.
Okay.
And people who eat more salt, they have more hypokalemia than people who eat less salt. Because the more salt you eat, the more sodium is excreted in the kidney and exchanged for potassium. So a high salt diet can cause more hypokalemia than a restricted sodium diet. And Dr. Pandey has mentioned about this elevated and non-elevated blood pressure, which is a very, very interesting concept. Non-cancer, no cancer, the whole world is divided. But there is some important message underlying, is even a small elevation in blood pressure, if it is continue, by the way, the blood pressure always continues to go. If it stays like that, no problem. It continues to climb up with passage of time. I just calculated, if there is a 2 millimeter increase in blood pressure, which most of us ignore, are 2 millimeter, kya karega, goli maro, and all these things. But if 2 millimeters blood pressure, every second, every minute, every hour, every day, increases the blood pressure by 7 crores 50 lakh millimeters of mercury over the year. And that's a lot of blood pressure. That's a lot of blood pressure. I just calculated it.
Thank you. Thank you. I think we are going to close it. Just before that, Dr. Venkatraman, it's a really privilege for us to have Dr. Venkat. He's an authority, the world authority of hypertension. We are really privileged and honored to have you here, sir, this evening. And he has contributed profoundly in guideline of hypertension, the therapeutic schedule and everything. So the last question is very interesting by Dr. Jha. He says that how to see night deeper and non-deeper and reverse deeper for blood pressure management.
I think the concept is a good concept, but makes no difference in terms of treatment. Because you give long-acting drugs. People always ask, why can't we give nighttime medication to prevent nocturnal hypertension? No trial has shown just giving nighttime will lower it. But if the patient is on multiple drugs, then one drug should be given at nighttime, whichever you want to give. Studies have shown. So, but otherwise, the concept is fine, but makes no difference in treatment, because most of the drugs we have are long-acting drugs.
I think we'll thank you. Just one more question, but that is not, this is a hypertension evening. So this question is for heart failure with reduced ejection fraction and CKD. So this question can be addressed privately to Dr. Tarabdar during the dinner time. And thank you, sir. Thank you very much, Dr. Ram, Professor P.S. Banerjee, Professor Abhijit Tarabdar, Dr. Sunil Leela, and Dr. Arindam Pandey. And you all for being a very wonderful audience. We could have continued the discussion for the night till tomorrow morning, tomorrow being Sunday. If anybody would like to continue to remain awake, please feel free. But I have to go, and I'm sure many of us have to go. But the discussion can continue for hours, for years, and for decades. With that, thank you very much. And I would like the IPCA person, Johnny Edwin, to address the vote of thanks. Thank you very much. Oh, sorry, I think before I finish, just one quick announcement. Dr. Ram would like to join me here. I think I must announce it that Dr. Ram has taken a great initiative with the support with the IPCAs and other things. That suddenly, about a week ago, he called, not 5 days ago, he called me that, Robin, I would like to release a capsule every quarter of a year which starts from this year, on hypertension. And it's a phenomenal. Then he sent some article to me and he requested me to write the editorial of the first issue. And it is a World Hypertension League initiative and basically for the public health campaign for hypertension, because it's a public health problem now rather than a medical problem. Thank you, Dr. Ramsu, to take such a wonderful initiative. I'm sure it's going to help everybody, physician, our patients population, our community. Then our patients are our own relatives, for example. And I, as a person, as a doctor, I'm yet to find a single house in the community where any member of the house is not without any tablet. That is the current community of India, perhaps in the entire world. So great initiative, and and I personally feel being privileged and honored when Dr. Ram, stature like him, requested me to write an editorial for the first issue. Thank you, Dr. Ram. Would you like to have a word about this capsule?
No, we'll see how it goes. It's an interesting initiative, once a month. And I have taken one role in this, not a major role. He's going to write the guest editorial. Every month, I am going to do what is called a hypertension roundup from the world literature. All the major publications for that month from all around the world, I am going to give a synopsis, a compendium of publication implications for India.
Thank you. And big hand for Dr. Ram. Johnny.
Good evening, doctors, and thanks for all the valuable presence today, the great audience today, which was full packed. And our heartfelt thanks to Dr. Ram sir, because yesterday he was there, he traveled all the way from US to India, and today at Hyderabad in the afternoon, from Hyderabad to Kolkata. And of course, Dr. Rabin, Dr. Tarafdar sir, Dr. Arvindam Pandey sir, Dr. Sunil sir, and as well as Dr. P.S. Banerjee sir for their valuable time. And definitely chlorthalidone was one of the inspiration that we took way back in 2011 with the 6.25 mg dosage, and which created a path for many of the people to follow. And a lot of the work that we did, which has got an international reputation, and even the international guidelines have also looked into this, considering this molecule for in their guidelines. And our heartfelt thanks to each and everyone for extending all your valuable support in and helping us to come up with such newer molecules and with the newest informations as well. Thank you all, and do join for the dinner.